Great. Thank you very much. I'd like to thank the Society for the opportunity to present. I'd also like to thank Terumo. I don't have any specific disclosures, but they are a sponsor of this meeting, and we'll kind of go through one of their devices and some case examples. So again, I have no disclosures. So the distal aortic arch aneurysm. So traditional management of distal arch aneurysms, especially when these extend for a long distance in the descending thoracic aorta, has traditionally been a two-stage open approach. The first operation is typically done through a median sternotomy with a total arch replacement and leaving a segment of elephant trunk graft hanging down into the descending thoracic aorta, typically 5 to less than 10 centimeters in length. This is a huge operation for many of these patients. It takes a while for them to recover, and then you have to talk them into the second stage of the operation, which is most of the time even a more involved operation, as that involves a left thoracotomy, going in and clamping the elephant trunk, and then completing an open descending thoracic aortic replacement. So these are two sets of really morbid operations. In many series, less than half of the patients return for the second operation. And in this interval time period, especially when you have a very large descending thoracic aneurysm, there's not an insignificant risk of rupture of the aneurysm while you're waiting for these patients to recover from the second operation. So here's a typical total arch replacement, as you can see here, where you're going all the way past the left subclavian artery there and sewing into the descending thoracic aorta. You invert a segment of graft into the arch graft that you have, you sew that suture line, and then you evert that graft and let it free float into the descending thoracic aorta. So multiple hybrid operations have been proposed to lessen the physiologic insult of that second major operation. This typically involves placement of a thoracic stent graft in the descending thoracic aorta and including this in the distal suture line at the index aortic arch operation. This frozen elephant trunk in the descending thoracic aorta can then be used as a landing zone for a completion TVAR, or in the setting of even a patient with connective tissue pathology, you can still do a left thoracotomy and use that as your site that you sew to and clamp into the descending thoracic aorta. So it leaves you with different options for these patients. So, originally some of these hybrid operations were deployment of a thoracic stent graft under circulatory arrest. This is one described by the group at Penn, kind of doing an extended hemiarch, taking that all the way over to the left subclavian artery, bringing the layers back together, incorporating a thoracic stent graft into your distal suture line, and then sewing around the head vessels. Eric Roselli at the Cleveland Clinic described this Be Safer approach, branch stented anastomosis frozen elephant trunk repair, where essentially they're taking a thoracic stent graft at the time of open circulatory arrest, gauging where the origins are of sometimes just the left subclavian artery, sometimes also the left common carotid artery, and punching a hole through the thoracic stent graft, taking a branch graft directly into the origins of those vessels, and then ballooning that open, so kind of an on-table under circulatory arrest physician modified graft. And then you can also, all these different variations here with either multiple stents and or branches going to the head vessels. And they've had decent results with this as well. A newer way that has been specifically designed is a kind of a standard zone 3 arch frozen elephant trunk, and we'll talk about the Terumo Thoraflex device next, which incorporates a thoracic stent graft into an open arch graft. And so it comes in two different configurations. The first one you can see there is typical for debranching all of the head vessels. The downside of this device is that they are fairly widely spaced apart. So if you're sewing at zone 3 with that collar that comes around, all of your head vessels come very proximal. So if you have a patient that their head vessels are very proximal, this graft can really bring the branches down below and can make sometimes sewing this to the sinotubular junction a little bit difficult. So you really have to kind of tailor it to the patient. In those options, one of the things that we've done sometimes is done an arch first, where you debranch all of the head vessels using a trifurcated graft, and then using this second graft over here where you can then really sew that into whichever zone you like, and then you can bring your trifurcated graft down and sew it directly onto this. So there's different options for each individual patient depending upon how proximal their head vessels are going to be and how much work you need to do on the front end. And so this is the kind of the two different configurations. One, each individual branches are used. I like to use that for patients that have connective tissue disorders because you're taking out their arch. The first time if you can do this all at their index operation, the first time they've had a sternotomy, that's the best way to do it. Going back and doing a redo sternotomy and trying to do a total arch is difficult. A lot of extra bleeding, a lot of extra time, a lot of extra circulatory arrest time. So if you have a known connective tissue patient, it's probably best if you're going to take an aggressive approach, do that all at the first index operation. If you had an older patient, you can do the head vessels as an island, which is faster, as you can see on the second cartoon there. So I was going to present a case. This is an 83-year-old female that I saw last month. She was seen by one of our vascular surgeons, had been referred for kind of asymptomatic moderate carotid stenosis. And I got to give him kudos. He examined the patient, the lost art of physical exam. Dr. Osler would be proud. He noted that the left side of her chest was actually pulsatile. It was kind of crazy. And so he sent her downstairs for a chest x-ray followed by a CT scan of the chest. And this is what they found. She had a 6.8 centimeter kind of distal arch aneurysm. You can see here that the aneurysm, how far proximal this comes. It's essentially all the way up to her sternum. All of her head vessels are pushed very, very, very proximal here into the ascending aorta. Fortunately, this was to the left side of the chest, so there was a clear entry through the front. But a very, very large aneurysm, and it had this kind of knuckle and bend right here. To try and do an endovascular total arch with these kind of severe angles and all of the head vessels coming off at a, kind of type 3 arch, that would have been really tough to do. And she actually, despite being 83, actually looked pretty good. She really had no medical problems, was not a smoker. To do this from the conventional, just an open descending standpoint, I think would have been impossible. A left thoracotomy trying to get to this area here from the left chest, which is now all the way anterior to the sternum, would be impossible. And so we've elected to treat her with kind of a two-stage hybrid approach. And so through this operation, I did an axillary cannulation so I could do antegrade cerebral perfusion up her right carotid. We also, because of her carotid disease, I stuck another cannula up her left common carotid artery at the time of her total arch so that we could do bilateral antegrade cerebral perfusion, and we did this through moderate hypothermia with a temperature of about 25. So we'll kind of go through some of this here. Here we've opened up the arch. Let me freeze this and talk a little bit about, oh my God, this thing's going crazy. All right, let me pause this. So the Thoraflex device, you can place this over a wire. One key point is that it's a monorail. So the thoracic stent graft has a little tiny hole at the end of the delivery system that a wire you can put directly down the aorta. And as you bring that down and put your graft where you want, a key clutch thing you have to do is you have to remove the wire before you deploy the graft. And the reason for that is basically if you tried to pull the restraining sleeve and release the thoracic stent graft, now still with this monorail wire, if you tried to pull the handle out, you've still attached that wire. It basically creates a V, and you would take your thoracic stent graft and pull it all the way out. So you absolutely have to pull the wire out, and there have been reports of that happening. So that's a clutch thing. So here we've put a wire down, and we're placing the device. Shoot. Let me try that again, sorry. You can take the device, you can bend it. So here I put the wire down. You have to orient it, obviously correctly. You can put a bend to the device, and her sharp angle there was kind of tight, so I wasn't really happy how it was going down. You can place these in the setting of an acute aortic dissection. I'm a little leery of doing that, but some of my partners have used this device in the setting of a type A dissection, but it is a little bit rigid. Here I pulled the wire out, and we're getting it into position. There's this restraining sleeve that actually you have to apply a fair amount of force. I'm probably weak, but and this is uncovering the thoracic stent graft and deploying the stent graft. There's a collar that's restrained inside of that little blue sleeve there. You cut the stitch, you open this up, and now you unfurl the cuff. which you're now going to sew around at zone 3. So here we're taking the head vessels. You can sort of still kind of rotate this some. You take the collar out here and you're positioning that around the zone 3 descending thoracic aorta, and now we remove the inner sleeve here. And again, you have to remove the wire before you take this inner piece out. And basically, you now sew that collar around the descending thoracic aorta, you clamp all of those branches, and now you reperfuse through the sidearm, just as you would any typical arch case. So here we're taking this collar and sewing it around. And surprisingly, this is relatively hemostatic.
Hey, Marvin, I think you're going to need to wind this up soon.
Yep. So there's the final picture here with the 3 branches. Here's the completion. I ended up using a 150 device to get past that corner, and then we're going to bring her back for a completion T-bar. And we'll just skip through this. I got 2 slides left. And so it ends up looking pretty good. She was in the hospital for a couple weeks at 83 after a total arch, not too surprising. Had several thoracentesis procedures, but otherwise went to rehab. We're seeing her in the next couple weeks for completion T-bar. So in conclusion, the device offers a hybrid option for distal arch aneurysms. You can use it in patients with acute type A dissection with malperfusion when you need to increase the true lumen diameter. It definitely simplifies the elephant trunk procedure, allows future T-bar if warranted. If you use the longer devices, it comes in 150 and 200. There is a higher risk of paraplegia. In general, if you were going to do this for a type A, I would probably try and just use the 100 device. Thank you very much.